So our next speaker is Dr. Lee Chapman. She's the Chief Nursing Officer of Canada. Dr. Lee Chapman's nursing career has spanned almost 20 years. And in that time, she has gained an in-depth understanding of nursing through a variety of clinical leadership positions in home and community care, research, academia, regulatory, and professional practice environments. Her background in direct patient services includes critical care, including the intensive care unit and emergency departments, community care, such as home care, harm reduction, and camp nursing, as well as education in professional associations, such as the Registered Nurses Association of Ontario. Most recently, Dr. Chapman was the Director of Clinical Services with Inner City Health Associates in Toronto. As the senior nurse executive responsible for developing, launching, and overseeing the program, she garnered significant change management expertise. Dr. Chapman has a Master's of Science in Clinical Health Sciences from Nursing Graduate Program at McMaster University. In 2019, Dr. Chapman completed her doctoral work at the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto. Her research focused on the competency assessment practice of clinicians in an academic hospital setting. And this provided her with key insights into ways in which the regulation of health professionals intersects with organizational priorities in an acute care setting. And with that, I'd like to welcome Dr. Lee Chapman to the floor.
Thank you so much. Merci beaucoup and bonjour tout le monde. I'm absolutely delighted to be here to kick off your summit. And I'm really thrilled with the theme of unity, because I think that's exactly what we all need when we think of all the different areas of specialization, all of the interprofessional teams that come into play when it comes to health services, healthcare delivery. We really need to come together as unified teams in really knitting the country together into what's best for patients and also what's best for providers. So I'm going to talk fairly briefly about what I've been up to since I've been in the role, and hopefully linking the work to what you do every single day at the point of care, or in research, in policy, and in all different aspects of care provision. So first I often get this question, so I thought it would be helpful to first perhaps start with why we have a federal chief nursing officer. Just in case some of you may be wondering what it is that the role entails and why we have this role. So this is a role that has existed in Canada since the late 60s, since 1968. It was eliminated in 2011 under Harper's Deficit Action Reduction Plan, and then reinstated in 2022 as a result largely of advocacy from the nursing community. About 70% of countries around the world have a government chief nursing officer, and sometimes that role is government chief nursing and midwifery officer, depending on the journey to licensure. But really important when we think about nursing in Canada as the largest group of regulated health professionals, really important to have that representation in government at the federal level to ensure that the contribution of nurses is recognized, and also to increase the visibility of nurses in decision-making at the federal level. Whoa, I don't know what happened there. Okay. Okay, I think we're good. Something was a little glitchy.
I just had to switch over 1 second. Are we on?
No worries, we're good. Yeah, this is fine. Oh, yeah, maybe if we can just go back, that's great. So I just want to mention at the time of my appointment, former federal health minister, Minister Duclos, was responsible for the reinstatement. And he talked about the central role that nurses continue to play in healthcare in Canada through their many contributions and expertise. And it's not to say that we don't all work and exist and play and operate in an interprofessional sandbox. That's the world we all live in. But really important to recognize that it's often nurses who are most proximal to the point of care, and have a large role when it comes to certainly pressure injuries, but also systems navigation. So I think you've heard enough about me in terms of what I've been up to, but just one little anecdote I wanted to share that when I was appointed into the role, the media article in 2022, the media article said, why would they appoint a doctor to a chief nursing officer position? And then, of course, you know, they say don't read the comments in the media articles, but of course you read the comments. And so some of the comments said, when was the last time she did wound care? And I can tell you that over the course of my, over the course of COVID for 2 years, I was director of clinical services, as you've heard. But in that interim period, when I was in the recruitment for the federal chief nursing officer role, I was actually working full-time in a community health center at Regent Park Community Health Center. And I was a casual nurse filling in. Of course, there's always a need for shifts, so I had my pick of the shifts. And the full-time nurse had actually gone on vacation for 3 weeks. So I was responsible for not just the care in the harm reduction supervised consumption site, but also those who were coming in regularly for wound care. And there was a gentleman who I was very, very nervous about taking over that care during the full-time nurse's absence, because he had necrotizing fasciitis, and he had terrible wounds, was slated to have skin grafts to both of his calves. And I was responsible for his wound care with big open wounds in a community health center. And so I think what really shifted the needle in terms of having regular wound care was actually nutrition. Because I was able to actually bring in the nurse practitioner from upstairs in the primary care environment and sort of figure out a plan. Part of the plan included cases of Ensure and ensuring that he could actually get nutrition also, in addition to Ensure, that he could actually get nutrition when he came into the site for wound care. So this was a summer where I was really dodging monkeypox, COVID, and this patient in particular had bed bugs. So I was really pleased to say that after the 3 weeks that the full-time nurse came back, his wounds had closed, and it was quite miraculous. He didn't need a bone graft. I sort of joked that the surgeon owed me a lot of money for the care that I had provided, and that semi-expert wound care, but also that collaborative environment. And I think working very closely, ensuring his nutrition also was up to par to really optimize wound healing. So just a little example that, you know, there are nurses who are PhD prepared, and so if you see someone called doctor, it doesn't mean that they're also not a nursing expert and can do other things besides policy. In terms of the role, my role is a policy role. I'm within the health policy branch of Health Canada. My role is to provide strategic advice from a nursing perspective. And it's always with that lens of what's best for the patient and what's best for the provider. This was always my North Star in COVID when we were developing a new program for people experiencing homelessness in hotels and in a very, very different environment. And that really is my lens still now in the federal government. It's always what's best for the patient and what's best for the provider. And often I'm working with folks who don't have a healthcare background, who are in the policy world. In that bureaucratic machine. And so that's a really important lens. It can be anything from ministerial remarks to actual pieces of policy and things we're trying to move from a federal perspective. I play a convening role. As you know, we fund healthcare federally. How it is managed and administered is up to the provinces and territories. And so we play that convening leadership role, which can be difficult. We mounted the largest vaccine campaign in Canada's history during the COVID-19 pandemic. And there are some jurisdictions now that are sort of saying, hands off, federal government. We don't want to have anything to do with you when it comes to healthcare. We know our population's best. But we did have a record investment in healthcare this year of over $200 billion. So certainly an important convening role to play when it comes to ensuring that we do have the principles of our Canada Health Act upholded in our different health systems across the country. And then I represent the government both within Canada and internationally, but most of my work has been domestic. And I will say that although my work has really been squarely focused on workforce, you can see so clearly how workforce and an issue like pressure injuries actually coalesce, right? If you don't actually have an adequate workforce, you're going to have negative patient outcomes, and it's really going to have a negative impact on morbidity and mortality. And so that's the lens of providing strategic advice, ensuring that we're actually connecting the dots on these things. It's not just about bums in seats, about healthcare providers and filling vacancies. It's actually ensuring that patients get the care that they deserve. In terms of what I've been up to for the last almost 2.5 years now in the role, I've really been prioritizing engagement. So ensuring that I am connected to the nursing community in Canada, which is very vast. We have 10 provinces, 3 territories, 2 official languages, 4 different categories of nurse. We also have all different areas of specialization, some of whom have really cool acronyms like NSWA. And ensuring that I am really connecting with all of those different groups in the nursing community. I made a commitment to visit nurses in every province and territory, which I was able to meet that goal by January of this year with a very frosty visit up to the Northwest Territories. And one of our what we call FPT, or Federal Provincial Territorial Groups, is the Principal Nursing Advisors. So this is comprised of all of the government chief nursing officers or equivalent from every province and territory. Not every province has a government chief nursing officer, most do. And for those that don't, they have a policy delegate. And we meet monthly and talk about all sorts of mainly workforce issues. One of which I think is important to mention is the issue of staffing agencies. So there's a great example of when we have a contingent workforce. When you don't have that continuity of care, it can have an absolutely detrimental effect, especially on an issue like pressure injuries. Another group that I have convened is the Federal Nurse Executive. So the federal government is often considered the 14th jurisdiction. If you think of 10 provinces, 3 territories, plus the federal government has a large nursing workforce. And these are folks who work in Correctional Services Canada, Veterans Affairs Canada, Indigenous Services Canada. The Canadian Armed Forces has a military and a civilian workforce, Public Health Agency, ESDC. I think I'm forgetting one, but that's the large majority of the nursing workforce within the federal government, and everything is quite different. The union issues are different, the workforce, the job classifications are different. And one thing you may be actually quite surprised to hear is that I had a chance to visit a correctional facility. There's actually 3 federal correctional facilities this summer, and the number of inmates or patients, clients in federal correctional facilities who actually require total care. They have hospital beds, they are not able to get out of bed. Certainly many are geriatric, but not all. And so when you think of chronicity, how it is actually impacting that offender population as well, and the way care is delivered when you have a small cell in a hospital bed, really, really hard to deliver care, especially when you have products, wound care products, even personal care products that are often seen as a commodity in that environment. So nurses are very, very challenged to deliver competent care in that kind of environment. And all of that engagement with nurses across the country, it's been really key that there's a need to focus on nursing retention. So in the fall of 2022, when I started, we had, I think, been through perhaps some of the worst of the COVID-19 pandemic. And we're really starting to talk about a resilient workforce. And nurses felt gaslit. They felt like it, if we were talking about resilience, it was really undermining the experiences that they had endured during COVID under the duress of the pandemic, the shortages, the difficult staffing, but also the difficult actual care. I talked to very seasoned critical care nurses who said they had never seen so many deaths. In fact, often it was couples partnered couples or married couples who are both dying in the ICU simultaneously, doing end-of-life care or saying goodbyes by iPad. So these were really unprecedented things. And there was also a lot of policy work being done on recruitment. Most schools across the country increased enrollment in nursing education programs, really seeing the devastating impact of COVID on nursing education. And so provinces and territories increased seats to nursing education programs. Schools had to follow suit. There were also recruitment bonuses that were popping up, whether it was at the jurisdictional level, come to Saskatchewan, get a $30,000 sign-on bonus, or if it was at the organizational level. We know that we can't recruit our way out of this crisis. It's a global nursing crisis. We need to actually look at how we're doing the work differently. And that really led to the need to focus on nursing retention. So I convened an advisory group, held a large pan-Canadian nursing retention forum in June of last year, and then together co-developed this nursing retention toolkit. I will just say that nursing doesn't own retention. So there are features in the toolkit that are certainly generalizable to other health disciplines. But in the toolkit itself, there is a very strong spirit of it being created by and for nurses. I think that nurses across the country felt that we were reflecting things in this toolkit that nurses have been saying for decades. And there's certainly some benefit to having it all in a Government of Canada branded document. And it's available in both official languages on the canada.ca website. So I really urge you to have a look at the toolkit. It focuses on these 8 core themes that you see color-coded in the outermost wheel. And we think these are themes that impact a nurse's day-to-day working life, primarily in the domain of clinical care. But the tools and initiatives are all really aimed at the employer or health authority level. So they're not things that an individual nurse must do to improve their own retention. They're things that structurally need to change in terms of how we are improving the working lives of nurses in Canada, how we are optimizing nursing work. So again, it was created in this interprofessional context, but definitely has a strong spirit of being created by and for nurses. And the themes that you see in the color-coded wheel, again, they're in a wheel to depict that there's no theme that's more important than the other. They're all equally important. And the themes are underpinned by the values that you see in the innermost circle, the values being respect, transparency, anti-racism, anti-oppression, and accountability. So I will talk briefly about the themes of the toolkit, but really, again, urge you to go to the canada.ca website to have a look at the toolkit. What you don't see here, or maybe I'll tell you what you do see first. So you'll see the 8 themes. There's a goal statement for each of the themes, and then all of the themes have 3 initiatives, with the exception of safe staffing practices, which just has 2 initiatives. What you don't see here is all of the references, resources, and examples. So in the toolkit itself, we've actually provided examples of where these things are happening already across the country. Over 95% of the examples are Canadian examples. We just had a few international exceptions for things that don't exist yet in Canada. But I think the sweet spot of the toolkit is really in those examples, because you can see where things are already happening, see that these things can be scaled and spread to your organization. So I would say that, again, all of the themes are equally important. I would maybe highlight a few themes that are getting the most attention. Definitely flexible and balanced ways of working is getting a lot of attention. But I think the theme itself perhaps is a bit misleading, because if you look at the initiatives, they're about flexible work design, which really is about ensuring that we have flexibility in how we're staffing and scheduling, that we actually have, for example, job share or self-scheduling. But then we're also automating our scheduling systems. Flexibility, I should say as well, is not just about staffing or scheduling. It's also about flexibility in care delivery. So an example I often highlight is the shared health provincial float pool in Winnipeg in Manitoba, where they actually have nurses who work at Winnipeg Health Sciences. They work in the, a high acuity tertiary care environment, but they can also work 2 hours outside of Winnipeg in a community hospital where it's more generalist. They have their travel and accommodation paid, but they're still within the provincial system. And this has been one of those models that if you build it, they will grow, or they will come. What's the field of dreams? If you build it, they will come. Most of the nurses that they've hired have actually come back from staffing agencies. And nurses want this variety. They want this practice variety. It's almost looking at the unit-based or hospital float pool environment and actually looking at how you can magnify that on a regional level or across site, across multiple different sites. But another initiative under flexible and balanced ways of working is workplace resources and amenities. So I often give the kind of pejorative example of other industries that have bubbling, sparkling water on tap, beanbag chairs, ping pong tables, all these things to promote collaboration. And when you think of the work environment for most healthcare facilities, there's not an adequate place to take a break, to have proper nutrition for yourself, to actually perhaps look after yourself, to, work out, exercise facilities, and even places for collaboration are few and far between. I know you can all probably relate to the challenges of booking a room if you want to have a large meeting. So thinking about how we can actually look at workplace resources and amenities, we provided examples in the toolkit of daycare for shift workers, parking and transit subsidies, ways to actually subsidize housing. Housing is often the critical issue in rural and remote parts of Canada, as well as the north. You can actually get the staff, but you can't house them. So we really need to look at this, not just in rural and remote parts, but in urban centers where transit, parking, and housing are increasingly unaffordable. So another theme that's getting a lot of attention is reduced admin burden. And this is really about freeing nurses up to focus on those essential and core aspects of care. It's really about redesigning the work environment, ensuring that we also have digital preparedness and digital tools to support for digital support and decision support. And that we also ensure that the documentation requirements within the organization are not burdensome to the nurses. So we're very risk averse in healthcare, as we should be, because it really is truly about life and death, but ensuring that we're actually not putting that burden on nurses, that the regulatory requirements are not, the organizational requirements don't exceed regulatory requirements when it comes to documentation. And then I would say safe staffing practices is getting a lot of attention as well. We've seen the announcement around nurse-patient ratios in British Columbia, which was a collaboration with the BC Nurses Union and BC government. And a similar safe staffing framework was negotiated in Nova Scotia in their recent round of collective bargaining. This is the first time in Canada that we know that ratios are being implemented. So we're actually funding the Canadian Federation of Nurses Union to collaboratively host a summit next week in Ottawa on this topic, to really look at how it improves, look at the evidence from Canada and from around the world, but also look at what difference it makes for patient and provider outcomes. Ultimately, safe staffing practices, I think we need to shift our thinking about ratios or safe staffing practices, that they're not actually a labor initiative, that they're actually something that's beneficial for patients. So have a look at the toolkit. There's lots in there. And again, it's not, although it is a nursing retention toolkit, there are themes that are certainly generalizable to other health professionals. We don't own retention in nursing. It is an issue that certainly crosses other health professionals. So just thought I would end with a bit of policy pieces of work that's been underway in addition to the work on nursing retention. So we have annually, we have a very big federal, provincial, territorial ministers meeting. They do meet more than once a year, I assure you. And in fact, the meeting was supposed to be last week in Nova Scotia, but because Nova Scotia called an election and is now in interregnum, we have postponed the federal, provincial, territorial health ministers meeting because it's always a federal and provincial host. And so Nova Scotia, of course, couldn't host as they're in caretaker mode. But last year, we had a very productive federal, provincial, territorial health ministers meeting on Prince Edward Island, and the ministers all agreed to these shared 5 priorities. So I thought they were worth mentioning here. Certainly, you see the first one being on retention. We also committed to undertake a supply and demand study of our domestic education. So how many health professionals we're producing annually? Excuse me. And we did this study across 5 key health professionals. So we did physicians, all 4 categories of nursing, PT, OT, and pharmacy. And we really looked at this, did some very sophisticated modeling, looking at it with Stats Canada to look at our projected demographic changes, including changes to immigration. And looking at how many key health professionals we are producing. And so this study will be released early next year when we do have the federal, provincial, territorial health ministers meeting. But another piece of this study was to look at Indigenous people. And we know that they're very underrepresented in health professions, but did a deep dive of their access to health professions education in general. We also are looking or have been looking at foreign credential recognition and ethical recruitment. So this is, ensuring that we actually have an expedited pathway to licensure for those who choose to come and work and live in Canada. We want to ensure that we make Canada a country of choice for health providers, but also ensuring that we are abiding by the Global Code for Ethical Recruitment as a member state organization in the World Health Organization. We need to ensure we have an agile and nimble workforce, and labor mobility, I would say, is probably the toughest nut to crack because it doesn't actually increase the net number of nurses in Canada or health providers. It really just improves their mobility. But this is, again, very pro-retention, and it's something that health providers want. And in fact, it's the way care is delivered across Canada. So if we think of during the COVID-19 pandemic, the really emergence of virtual care and how that means that care actually transcends borders. If you think of, somebody coming from the territories down to one of the southern provinces to receive care, if they're going back or once they're going back to the territories, the person who may be providing continuity of care from the southern province needs to actually be licensed in that territory in order to provide care. For those of you who came from Edward Province to attend this conference here in Toronto, you didn't get health insurance, you just brought your provincial health card, and hope you don't have to access our system here in Ontario. But if you do, you're able to, and that really is how care is delivered across jurisdictional borders. And there's no better example than the evacuation of Yellowknife last August because of the wildfires, where they evacuated the Stanton Memorial Hospital, long-term care facility. So nurses who were evacuating patients on charters needed immediate licensure in BC or Alberta. So we're doing some work to try to move that along, as difficult as it is. And then workforce data and planning. We have very poor integrity of our workforce data and planning. The latest data from the Canadian Institutes for Health Research shows that we have about 477,000 nurses in Canada. And we know that if nurses are licensed or registered in more than one province or territory, which many are, we're actually counting them twice. So we have funded the regulators to implement a unique identifier, which will actually eliminate the double counting once it's implemented by next year. But we really need to do a lot to improve our workforce data and planning, and have funded Health Workforce Canada as a means of, as an organization to be arm's length of Health Canada, but also arm's length of CIHI to do some of that modeling and sort of the narrative behind the numbers. So lots of really productive work going on, all really centered on health workforce. But as all of you know, workforce and patient outcomes are integrated, and it's really important to actually see them as such, because otherwise we're doing policy work in a vacuum. So I think that brings me to the end. Just wanted to really thank you for this opportunity and for the collaboration across the country. It's imperative that I actually hear from providers across the country. I think we still have some time for questions, because it's really important in thinking about how we can all work together and bring some of the solutions forward. I will just say, in case you're not aware, the president of the Canadian Nurses Association, which is our national nursing association in Canada, is actually an NSWOC and expert in wound care. Kimberly LeBlanc, many of you probably know her, but really delighted with the conference theme of being united in pressure injury prevention, management, and policy. So I welcome any discussion and questions, and thank you very much. Merci beaucoup.
Okay, so now the microphones are on the floor for our in-person to have the opportunity to engage with Dr. Chapman.
Hi, thank you very much, Dr. Jane, and thank you, Lee. That was just fantastic. And well, kudos for you early in your tenure as chief nurse to have pulled together such an amazing retention tool and being cross-country consensus is really something outstanding. So congratulations on that, I really must say. The other piece I wanted to mention is that when we talk about retention, I think nurses, all health professionals are looking for some acknowledgement around the standard of care that must be met in critical areas. And of course, in this room, we're looking for standards of care around wound care. And I wonder if you could give us some advice on how we, as a collective, might influence a national strategy on wound care, so that we might have strings attached funding to provinces that really might then impact solid focus in a standardized way on some of these issues, starting even with pressure injury.
That's a great question. I think that I think a lot of the things that I heard briefly this morning, you know, I think you said there was a patient voice here, ensuring that you're actually hearing from somebody who has been impacted by pressure injury. That's key for decision makers. I think it's also the link to safety in general, safety and quality writ large. So perhaps linking with one of the pan-Canadian healthcare organizations that does receive federal funding, like Healthcare Excellence Canada, would be one means. I think that coming together in a summit like this is critically important. And at the end, if you are able to coalesce on standards, I think that is actually what provincial and territorial governments and health authorities need to work towards. In terms of getting the strings attached funding is often for what the provinces and territories say is most important in their jurisdiction. So I think where you may get the most traction is actually at the organizational or health authority level. If you had an organization saying, you know, I'm going to use I don't know, we want to be like the gold star. We want to have a gold star in wound care, and we're recognized for wound care in this area. If that doesn't already exist, I'm saying gold star, there's probably some better analogy. But having some kind of organization or health authority, almost accreditation, would be really helpful. In really sort of shifting the needle and for decision makers. I don't think it's something that is often ignored, right? Pressure injuries, unless it makes the headlines. And I think that ultimately organizations are comprised of people. So it's people bringing those issues forward to organizational leaders and actually saying these are things that are entirely preventable, and really at the hands of at the workforce, right? But that decision-making happens at the organizational level. So I think coming together in a concerted way is key. That was just a bit of a flight of ideas, but hopefully some helpful pieces of it.
We have to try to get the attention to the $12 billion cost of wounds.
That's right, yeah. Yeah.
Well, we have a couple other questions. There were some questions from online about whether we'll be able to access the presentations later. It is being recorded today for anyone who came a little bit late, or if you have to leave early today, this will be available on demand after. Not the slides themselves, but the whole recording is a whole, you can do it digest. Question to that. Ms. Harley?
Hi, the great presentation. I'm Kathy Harley. I have a question for you around nursing specialization. So we know that it's very important in a healthcare setting, in organizations, facilities, wherever you work. That staff mix is very important. And it's important to have nurses who are specialized and nurses who have ongoing maintenance of competencies through CNA certification in many cases. What is the plan to look at getting specialized nurses recognized from hospital to community moving forward? I think it's really important, and it's important that from an administrative level, that nurses who invest in their education in wound, in ostomy, in continence, or any other specialization, mental health, OR, ICU, are recognized, are compensated for the value that they bring through their education and the value they bring to patient care.
Yeah. Great question. And I will just say one of the increasing trends that we're seeing is the regulators, as regulators exist at arm's length of government. So they get their authority essentially to protect the public by virtue of provincial and territorial governments. And regulators are increasingly interested in generalist practitioners. So we've seen that most recently in this September with the move to NP education being really at the generalist level. Instead of having sort of a adult, pediatric, and even NICU, neonatal nurse practitioner, with the caveat that there are 2 jurisdictions that are keeping the neonatal. But in general, all of the nurse practitioner programs as of this September moved to a generalist all ages model. So that's a big shift. And in general, all 4 categories of nursing are generalist, even the psychiatric nurse. So even though that is sort of specialized, you could say specialized education, their initial nursing education is focused on psychiatric nursing or mental health, they still have generalist competencies that they can work in a wide array of settings. And so that actually opens the door for specialty certification, as you've said. And I think that this is an inherent tension, because you can say that you graduate a generalist nurse, and the minute they work in a specialized environment, even as a new graduate, they're a specialist. They're working in a specialized environment, often without those skills. So the burden is really on the organization to actually bridge that gap. And this is where it's a huge problem. So I mentioned the top 3 of the 8 themes that are getting the most attention. Professional development and mentorship is not getting a lot of attention. And I think it's because there's such limited funding for professional development. So most organizations that I've spoken to have to rely on philanthropy or private investors like private companies like TD supporting professional development or industry. Seeing all of the displays around the room here, really, there's a real lack of funding for professional development and supporting that specialty education. So it's something that we are certainly looking at. I think it is a key role for the professional associations to play, like CNA. You mentioned CNA specialty certification, but again, it has to be with organizational support, and that's sometimes lacking and very, very difficult to fund. So I don't really have a clear answer, but it is an issue.
Maybe I'll ask one quick question.
Yeah.
So the context for wound care has changed quite a bit in the last few years. I wonder if you have a insight in terms of how we can address some of the social problems. We know wound care has been significantly linked to mental health, substance abuse, and house and home issues, and so many different layers. So as a, do you have insight in terms of how those issues can be addressed? I'm saying in terms of the landscape of how we provide wound care has changed so much over the last 5-10 years, especially since pandemic. I think this is exacerbated issue for with the labor, the social environment, issues around house and home issues, substance abuse, mental health. And those are people coming into hospitals with wounds. And we don't really have any way to address those issues even better. I mean, your story is such a good example, and those are people who see on an ongoing basis.
Yeah, I think that you do have a way I would challenge that, because I think that I think you do have a way to address those things, because healthcare is relational. And I think that even as chief nursing officer, I've only been able to advance initiatives because of the relationships that I have across the country. And so when you have patients coming into care, even though you can't house them, you can build a relationship with them, and you can build a trusting relationship so that they're actually coming back for care and getting follow-up care, and they're not lost to follow-up. And so I think that can be life-changing in and of itself. I know that, the nursing lens is also very, very astutely focused on the social determinants of health. So bringing that broad holistic perspective. And connecting with what limited supports exist and are available is really key. But ensuring that, I think that people need to hear that you care about their social issues, even if you're unable to address them. And that's all about the therapeutic relationship that often happens when you are doing the actual tasks or doing the work of a wound care dressing. It's actually having those conversations, getting to know people as people. And I think that in general, there is a hypervigilance around healthcare, whether you're housed or unhoused. People come in and they have, consulted Dr. Google, and they think they know everything about what they need. So it really does behoove us as health professionals to be those knowledge brokers, to build those relationships. And I think that actually moves the needle on care.
But that's excellent. I think that's the nursing voice that comes through in terms of what we do.
That's right. Yeah. And advocacy. I mean, I think advocacy isn't some big esoteric thing. It's not, necessarily marching down university with a placard and, shutting down an intersection because you're doing a protest. Advocacy is what we do every single day, whether we're advocating for patients at the point of care, for our colleagues. I think it's so important. And it can change things, whether it's changing things in policy or changing things at the patient or provider level. So that nursing voice, that advocacy voice, is critically important.
And I'm a clinical nurse specialist working alongside Josh and Vinny working sort of beside me. I have two things. One is to comment, and the second would be a request. So the comment is to share with your story so that you know that every week my heart is broken because of the medications I see in our patient population, and that patient population is the spinal cord injury, where they're at risk, no matter what, no matter the level of their injury, they're at risk for pressure injuries. So we do see a lot of these patients every week. My heart is broken many times because of the wounds that we're seeing that will never. They do need some type of a surgical intervention. So as you were just letting us know that you do a lot of advocacy in your job, my request is if you could please, as you're doing those advocacy, advocate for a program, maybe a best practice intervention to help our patients with those advanced pressure injuries that will never heal, to have some type of interventions surgically. And I know our leaders within our program here have written many proposals to get funding. So I'm just wondering, and I'm asking, and I'm thinking, because our hearts are breaking, to advocate for our patients for surgical intervention.
Thank you. That was great advocacy. I will just say, maybe from a research perspective, I am speaking with the governing council of CIHR on Wednesday. So this is something that I can bring forward about not just health services research, but also patient outcome directed research. So it's a great. I'm sorry your heart is breaking. I will carry it forward. I commit to doing that.
Are there any other questions from our in-person attendees? Dr. Chapman's here.
This is the appropriate position to ask, but my question would be, you have an amazing tool out there. I think I'm out there. You have, the toolkit was amazing for, and for somebody like me who's sitting in my office and doing just patient work, we leave this kind of stuff to our managers and we don't get exposure to this. I was actually thinking my manager should have been here to be exposed to this rather than us. But is there a plan? The toolkit is there. Is there a plan to somehow create an incentive for the hospitals who implement the toolkit? Because you have it out there, we all know we want it.
Yeah.
All of us here know we want it, we need it. How are we going to get to this? It's my question, and is there an initiative coming from, I'm not saying federal government, I'm not saying government, but I'm saying somebody is doing something to see that this toolkit is used.
Yeah.
I mean, we have toolkits for everything. That's
We do.
everything.
We do.
It's not, I mean, it might be the elephant in the room, but
No, it's true. There are toolkits for everything.
we do have a disbursement plan. I don't know, maybe that's not the correct wording, but that's what my question.
It's a great question. I have a dissemination plan, and the toolkit certainly has been what I've been talking about. I don't have a CNO checkbook, if that's what you mean about a disbursement plan. I wish I did. But you know, a lot of I think a magic really is in the bilateral agreements that the provinces and territories have signed, because some of the provinces have committed to specific targets on retention. And that's really at the jurisdictional level, at the provincial or territorial level. This is something I talk to often to hospital CEOs, for example, where they'll say, well, where are we going to get the money? And I talk about how there's been a record investment in healthcare, you know, over $200 billion. But ultimately, organizations are already spending the money. They're spending the money on turnover, they're spending the money on vacancies, and sometimes they're spending the money on poor patient outcomes. So this is, I mean, I think it's okay that your manager isn't here, because I think this is something that can be brought it certainly is, the recommendations are aimed at the organizational health authority level, but it can also be a grassroots initiative where nurses bring forward the recommendations from the toolkit to a professional practice council, to organizational leaders, and say, you know, we're not doing well on 2 out of 8 of these toolkit themes. This is what we actually need to focus on. You know, nurses, for example, will drive by 5 hospitals on their way to work at their one chosen site. And over time, unless we're changing what actually is appealing in that work environment, often nurses will say, well, I like my colleagues. They'll say colleagues first, and then they'll say patients often. In chatting with nurses across the country, sometimes it flips. Sometimes it's like, well, I'm there for the patients, but often it's, I like my team and I like my colleagues. That's what keeps me going into the work environment. But over time, those things will be less appealing unless we're actually changing how we're optimizing the work environment, how we're challenging nurses, how we're providing flexibility and variety, how we're supporting professional development. So I think the toolkit, I mean, we are federally certainly looking at how it's being implemented. We're doing that analysis. And certainly it's something we talk about to all of the principal nurses every month, as well as the federal nurse executives, how they're implementing the toolkit, how it's being implemented across the country. And there are early adopters who have sort of taken the toolkit and run with it. I know VON Canada is using the toolkit. I know there's many provinces that are using it as their framework for strategic planning at the provincial level. And there's even organizations that I've heard have used it for a staff satisfaction survey, org-wide, like beyond nursing. So it is a bit of a choose your own adventure, but in the absence of a CNO checkbook, I think, you know, there are funds on the table. There's more money than there ever has been before in healthcare. And so it's up to us to really, you know, raise the issue of pressure and raise to organizational leaders and to provincial and territorial leaders as well.
Well, Dr. Chapman, thank you so much for indulging us with your presence today. It was such an excellent presentation. So Dr. Chapman did raise a couple of key points along the way, and there are a couple of things that resonate to me a lot. And one of them is highlighting the role and the valuable role of nursing in the process to ensure appropriate care delivery at bedside. I also like the fact that she highlighted the integral role of collaboration to address the multifaceted needs of the population we serve, from ongoing wound assessment to wound care, to the need for optimizing nutrition, rehabilitation, and even most importantly, addressing the patient-centered concerns so that the care we provide is unique and individualized. I also like the fact that that Dr. Chapman highlighted the lack of staffing resources will have a negative outcome in care. And the reason being that resonated to me a lot is because sometimes we are implementing a lot of standards of practice. It's one thing to implement standards of practice, but if we don't have adequate human resources and we don't have adequate resources to implement these things, then this becomes abstract thought that just keeps on the theory side of things without being applied in clinical practice. So that is really, really important to me as well. And thank you for introducing us to the Nursing Retention Toolkit to improve the nursing lives of nurses across Canada, that then in turn improves the quality of care for everybody else. So thank you so much, Dr. Chapman.